everyone, it's a dose of Dr. Drew.
Restream is not on, or maybe I'm not in it properly. Let's see here.
I see eyeballs, but I'm not sure. I don't see anybody's chat.
Yes, nobody's ringing in yet, but we'll give you a chance to pile in here before we get it on.
I don't know. It's been a very strange day.
Hi, Jessica from New York. Hi, Linda. We'll give you guys a moment to kind of pile on in. Strange day technically, Susan?
Yeah, I don't know. It's just weird.
Some weird technical stuff. All right, give everyone a chance to come in. Hi, Andrew.
You can introduce who's coming. I'm going to send her the link to
I will
Facebook.
In mere moments. I want to introduce her in front of everybody. I want to give everybody a chance to come on in here. So we have another great guest today. It is Dr. Anne Rimoin, Professor of Epidemiology at the UCLA Fielding School of Public Health and Infectious Disease Division of the Geffen School of Medicine. She's the director of the Center for Global and Immigrant Health, and she's an internationally recognized expert on emerging infections. She is conducting a large study now on healthcare workers and first responders. They are gathering data of UCLA healthcare workers, LA County first responders, LA hospital workers. They're monitoring healthcare workers and first responders through antibody screening and active viral testing. If you wish to help out with this project in order so we can maintain our workforce at the front lines, it's giving.ucla.edu/
Actually, we have it drdrew.com/UCLA fund.
Okay. Just called UCLA Fund. There it is, drdrew.com/UCLA Fund, which is also connected to the Rimoin Emerging Infectious Disease Rapid Research Fund. So we want you guys to help her out there so we can keep our frontline workers, so we can understand what's happening with them. Susan, are you ready now for me to introduce Dr. Rimoin?
Yeah, go ahead. I'm trying to show this, but I'm slow.
All right, Dr. Anne Rimoin, thank you for joining us.
Happy to be here.
So first, tell us a little about the research and any preliminary findings that you've got to share. We'd love to hear them.
Well, thanks for asking. What we're doing at UCLA is that we are doing a study of healthcare workers and first responders. Now, this is really important because healthcare workers and first responders are especially vulnerable during these kind of rapidly evolving epidemics. China, Italy, other countries, they've all demonstrated the impact of what a pandemic can have on a health workforce. And we're seeing rates of infection among healthcare workers of up to 20%. It's a real problem. I'm sure many of you have seen these articles in the news showing how nervous healthcare workers are. They're right on the front line. They're the ones who are out there every single day being highly exposed to people who are infectious, who have the virus. And because of this lack of personal protective equipment and the difficulty with getting tests, they often are in contact with people who are symptomatic and asymptomatic. And so what we're doing is a project that is both research and service. The first thing that we're doing is that we're screening people. We just started, actually. We're screening people regularly. So everybody is getting a regular nasal swab, and this is the test that people do to determine whether or not they have an active infection. What we're doing is we're looking for people who have active infection, but they don't know that they do. So these could be people that are either infected without symptoms, or this is the moment right before they have symptoms. So they don't know they have it. And this is really important.
How often are you swabbing? Like once a week, everyone gets swabbed, or
every other week?
Every other week.
Every other week, we're swabbing people. And we figured we would do this every other week because every week it becomes kind of onerous to get so many people in. So every other week is what we thought was both feasible and reasonable for people. But it's really important because healthcare workers, they can, if they're asymptomatically or pre-symptomatically infected and they don't know it, they can give it to the patients, to their colleagues, and they bring it home to their families. And so this is obviously a major concern for them. So it's a really important piece of this.
Are you starting to break down any other aspects of the population that you're studying? Are you looking at genetics to any degree? Are you looking at whether they're taking supplements or zinc or hydroxychloroquine? Go ahead.
Yes. So this study it's multifaceted. So the first big thing that we're doing is we're trying to understand, are people infected asymptomatically or pre-symptomatically? And this gives people real actionable information that they can use. Then the second thing that we're doing is we're taking blood samples from people, and we're taking blood samples from them every month, and we're going to be screening them for antibodies, which everybody has been hearing about recently. All of the, an antibody test to determine if people have already been infected. But what's much more important than just finding out if you've been infected is that we're looking at their immunity. So we're trying to understand, okay, if you've been infected, are you actually immune to this virus? And those are two different things. And we're seeing, there's a lot of data out there that's suggesting that if you get infected, you aren't necessarily going to have immunity. You might, and it might be short-lived, or it might be long-lived. We don't know yet. Everybody is going to be different, but we're going to find out. We're going to drill down on this, and then we're also going to understand how long are people immune to this, and can people get reinfected? So this is really different than some of these other studies, which are looking just to see at one moment in time, does somebody have evidence of previously being exposed.
How are you testing for immunity? You can't really do Koch's postulates here.
That's a very good point.
Right.
So what we're doing, we're taking blood samples, and we're working at our lab at UCLA, and we are looking for antibodies. But after we look for antibodies, so let's say somebody actually has antibodies to the virus, then we're taking it and we're looking to see, do these antibodies actually neutralize the virus in a lab? So we're taking this and testing it against live virus to see if it actually has an impact on the virus. So that's really the difference.
Is that a absolutely predictive assay for immunity, or partially predictive?
Well, there's no assay that's perfect,
right?
But but looking to see that antibodies can actually neutralize the virus is the gold standard for determining whether somebody has immunity. It's the best that you can do. In science, everybody wants something to be black and white, and it never is. But this is the best that we're going to do.
I totally get that. And so, are you able to describe any of your findings at this point?
Well, we just started. We just launched on Monday. So our findings so far are that everybody is so desperate to have this kind of a study. Once we launched this, we have been deluged with people from UCLA Health, and that's where we started, just asking to be participant. Of course, everybody wants to know what their status is right now, but even more than just wanting to know what their status is, these healthcare workers need to know, have they already had this? Have they not already had this? And if they're asymptomatically infected, they can isolate themselves from their families or take precautions that are necessary so that other people don't, so that they don't get it.
Very interesting.
So our preliminary data is that this is a really important project that is providing service. And I think that the key here, and Dr. Drew, I think that you understand this more than anybody as a healthcare provider. If we are not doing everything we can to protect our first responders and our healthcare workers, they can't protect us. And so that's why it's so important. This information is critical.
Right, and it'll be great to know. You may pull out some genetic or prophylactic factors that could really have a big impact on the general population too.
Absolutely. So we're looking at this as well. We're going to be doing sequencing of virus. We're going to be looking at all of these things. Looking at cellular immunity, looking at humoral immunity. These are, I know, all big science terms that not everybody is going to understand, but that we're really looking at this in a holistic way and trying to understand everything that we can. And in addition, figuring out who's got really good, strong antibody responses that could serve as donors for convalescent serum, which is what people have been talking about, using people's serum or plasma can be used for people who are sick as a way to treat people, and might be able to be used in developing new vaccines and therapies to fight it. But another thing, and this comes straight to what you do, is that we're also looking at one of the other things that we're looking at is mental health outcomes and how stress, anxiety, stigma, all of these things are affecting healthcare workers.
Are you just using sort of anxiety and depression scales, or are you doing something more?
We're using the questionnaire, so we're using all of the standard anxiety, stress, stigma scales.
Right.
But the other thing that we're doing is that within this, we're trying to do this in an active way. That if we see that people are stressed, are anxious, that we immediately can refer them. So we're not just collecting data for the sake of data. We're doing something that has action as well.
Interesting. And just my own curiosity, are you breaking down anything about people that may or may not have experienced a cytokine storm? Are you looking at any inflammatory mediators or any of those post-hoc, mechanisms that might help us predict or treat the cytokine storms?
Absolutely. I mean, this is why. So we enroll people, we get these basic data, and then we have all of these downstream studies where people can get enrolled into more into some of these more in-depth studies for follow-on, and we need to collect more samples and continue this. So this is kind of the entry point, and then there are many other studies that they can be immediately enrolled into. But I think that the thing that the healthcare workers and first responders here, that's the other group that we're actually raising funds to be able to scale up as quickly as we can to cover the LA County first responders. Everybody, there's just not enough testing available to people and not testing on a regular basis as they need to be tested.
Right.
So we're just trying to do the best that we can to make sure that this need is covered while trying to understand all of the science at the same time.
I imagine, I'm hoping that you are able to rush to publication, at least pieces of it as we go, so we can find out what you're finding out in real time. Is that possible? Or you have to wait till you're all done?
Well, that's actually a really good question. And what we're doing right here is that we're actually setting up a dashboard so that information is available in real time. We just do not have, this is not a situation where you do research and you wait for publication 6 to 9 to 12 months later. This is information that is actionable in real time. So
tell me,
in this week, we'll be setting up
Can I get on that
dashboard?
Where is it? What's it called? I'm going to go on it right now.
Yes, you will be. No, we're setting it up right now.
All right, please.
So we're in the process of pulling this all together.
I am constantly looking for data to help people, because the big emotional thing people are going through is the lack of ability to know where they are and what the future holds. And the more data we can sort of look at it, it kind of reassures people that we're at least going in the right direction.
Well, exactly. And so the things that you'll be able to see are how many people have been tested, how many people have been retested, how many people are positive. Are they positive by serology? Are they positive for asymptomatic? So we're going to be able to see this in aggregate as this is happening in real time. And I think that this is one of the most unique things about what we're trying to do. And that's antithetical to research, right? So this is what we're, and I think that that's a very unique thing. I've spent my whole career working in emergency settings in other places where we don't, where we really have to be using the data we're collecting in real time. So I think that this is a unique situation here in the U.S. and I'm so glad to be able to be bringing what I do in other places in the world right here.
Do you agree with me that LA County should be applauded for their recent expansion in the viral testing? I mean, their website is so easy to use. They're guaranteeing everybody to get tested. I was just so glad to see this. Are you as enthusiastic as I am, or am I missing something?
No, I think that this is really important. I think that one of the things that I think is very unique about California in general is just what a great county department of health that we have, and they have been so proactive. As you well know, county health departments, the CDC, all organizations, research has been the funding has been anemic for, decades. And so everybody has suffered from that. And so I think that when we think about the failures that have happened over this epidemic, it hasn't been because we don't have a good health department. I think actually our health department is one of the best health departments throughout the United States, just really top notch people. I have several of my former students that are there. I know how good they are, but they are strapped for resources, and a resource, and you can't all of a sudden in, a matter of a month or 2 months change decades of poor funding for and pandemic poor pandemic preparedness. This is 100% an issue of pay now or pay later, and here we are paying now. We're paying a big price for having very poor funding. So that's a very long way of saying yes. I think what they're doing is good. I think it's great. We need more. They need more. And thank God for our county health department.
It's an unfortunate reality of how the human brain works. We have trouble dealing with other than crises. A distant problem is something that's hard to motivate for us to fix. And then once we come up with something like this, as we say, then we keep fighting the last war as opposed to preparing for the next one, which is the next bias that our brain puts us in.
Well, I've been spending my whole entire career telling people that it's better to prevent pandemics before they start. So I think this is one of those times that it's been very.
You can say it. I told you so. You can say I told you so. It's all right. You can say it's a safe zone.
I really wish I didn't have to tell anybody so. But it's really interesting. I have, for all of these years, preventing pandemics before they start. It's more important. It's so important. And I think everybody thought about this as some sort of an existential threat. And the movie Contagion or Outbreak and now people are seeing how real this is and how important this is.
Let me ask this.
It's really unfortunate.
Should we have had a more vigorous response to H1N1 back in 2009?
I think that H1N1 in 2009 was a different virus and a different time, and certainly, it was a moment where we could have done more, but we lucked out. We lucked out.
Kind of. It killed 500,000 40 to 60-year-olds worldwide, right? I got it. Nearly killed me. It was brutal, and I barely was aware of those outbreak when I came down with it.
Well, I'll tell you, of course we should have done more, but I feel like we lucked out because the U.S. I would say that most people don't even remember H1N1 here.
Most people don't know. Most people don't
say,
know.
Oh yeah, did we have it?
They'll say H1N1, but they don't know it was a pandemic. They don't know we had a pandemic 11 years ago.
Right.
I would say 90% of people don't know it.
We didn't have
iPhones. I think you're correct.
Yeah. And so my thing has always been, well, we had no reaction to that one, and then a massive reaction to this one. And to be fair, you can't really, it's apples and oranges. The R naught on this one is way worse, and it's a more nefarious virus, and I get it. But it just seems to me like we should have had a more vigorous response on the H1N1.
Well, we should have had a more vigorous response to so many things, and that's what I'm saying. The funding for pandemic preparedness has been anemic for a very long time. I don't think there's ever been adequate funding for it. Yeah. And when we were growing up, we were worried about missiles, not microbes, right? And that was where all of the funding went. And, that seemed to be a little bit more concrete to people than something that you can't see. You can see a missile, you can't see a microbe.
That's interesting.
And so I think that's just made it so difficult for people to understand so they could actually see it unfolding in their own backyard.
Interesting. So that's very interesting. And hopefully going forward, we'll have more appropriate and measured, we'll see, responses or preparedness to pandemic going forward. I think we will, don't you?
I do. I think, there's a thing I saw on Twitter. So this is not my own. I did not make this up. There was some graffitis that said that we can't go back to normal because normal was the problem in the first place. And that's true. I think that this will change our entire society and how we look at pandemic threats.
Can you be a little more specific about what that would look like? And is some of it short term and some of it long term, or is it all long term?
I mean, I think that short term, we're gonna this particular in this particular scenario, we're going to be, ramping up surveillance. We're going to be doing all the things that we have to do.
Right.
And we'll see strengthening right now, but in the long term, just like in any disaster, we're going to be able to have a way to look back and say, well, here's what we need to strengthen. And all of those things we know. We need to have a better public health force that is funded to do what they need to do. We need excellent disease surveillance. We need excellent contact tracing. We need excellent testing capacity. We need vaccines and therapeutics in the pipeline that are ready to go, and to be able to have funding for research so that these things are happening, in times of peace as well, so that we are ready for times of war. And I think that that's the real issue.
So let's switch gears for a second and talk a little serologies. A study out of Stanford and Santa Clara suggested that they were, at least in that little county, maybe underestimating the exposure to coronavirus by as much as 50 to 80 times. Any opinion on that study?
Well, this study is a very controversial study,
yeah.
and I would say that the first thing is, hey, this is a sero survey, so a study looking at blood samples and look at antibodies, and we need a lot of these sero surveys.
Oh, by the way,
and that's really important.
Is there a rapid antibody test out there that you can rely on, or are we ever going to have that? Is there one we should be looking for? I heard Abbott announce something today that might be available. Do you got any opinion there?
Well, I think that one of the problems with the tests thus far is that there could be cross reactivity, and so I think that many of the companies are still sorting that out. So I don't think that there's a perfect assay out there yet.
Right.
And that's something that, but I think that that's going to happen, and it's going to be happening soon. So some of these tests may not be as sensitive as we want them to do, or as want them to be, or as specific as we want them to be. But they're everything is moving in the right direction.
What's
right?
cross-reactivity?
So
meaning it's picking up other things other than the virus.
Right. Like, for example, I believe the Abbott test picks up cytomegalovirus as well, which could be a big, it could be mistaking, or another coronavirus, for example. And so, I would say that I'm an epidemiologist. I'm not a virologist, so I'll give you the from the epidemiologist perspective. I think that the tests are getting better, and that we will have tests that are gonna give us the information we need coming forward in the near future, and that's really great.
Yeah.
But you were asking about this study, and I think that people are very confused about this study.
Yeah.
And so I'll say, so the first thing I'm going to say is this study is put up on a website, on a preprint website. Okay. And so that means that this study hasn't been peer reviewed. It hasn't gone through all of kind of the rigorous reviews that normally need to happen before a study is published. And these preprint sites are really important because it's a great thing to be able to get data out there quickly and in real time, and for people to get eyes on it and to understand it. But I think that there are a lot of people have to interpret this with caution, because, as you know, many of these papers that we write they change quite a bit when they get reviewed by our peers. Right. And we get a lot of criticism and critiques that make these studies stronger, and somebody points out all the limitations, and it's very, very helpful. So it's, I think that that's the first thing to say. But the second thing is that, so as great as it is that this kind of study has been done, there were a lot of limitations to it. And I think it's not really a study that can accurately estimate the fraction of people exposed. This is a biased group of people. The recruiting was all done by a Facebook ad. There are no data on whether or not these people were symptomatic or asymptomatic, and that could really skew this, because one of the issues is that if so many of the people who actually went out and got tested were symptomatic, it doesn't mean that that changes what this study actually means.
Let's think about it this
right?
way. This was done in a time when testing was less widespread, and maybe it was symptomatic people who were motivated to go be in this study in order to get the test. So already you're selecting for the sick group. So, yeah. So, okay. So
That's exactly right.
We need more. And I was saying too, what about proximity to the San Francisco airport? There's all kinds of interesting things about that area. I mean, there's a lot more to be. There's something in the study, right? There's something going on, but what is yet to be interpreted, I'd say.
Well, I think that there's a lot of data. We don't know about the age. We don't know about the ethnicity. We don't know about the geography. We don't know so many things. And once they and this would have normally happened in a study that went through peer review, that all of these reviewers would have asked these questions, and we would have had a lot more information. So I think this, as everything else, it's all TBD.
So let me start to pick your epidemiology brain for a moment, if you don't mind. I like looking at the COVID-19.healthdata.org, Dr. Maurice Tov out of University of Washington. Is that a reasonable model for us to discuss?
Oh, absolutely. I think that Chris Murray's work has been really fantastic.
Okay.
And has given people a lot of information.
Oh yeah, it's been great, and it really up until his data, what the press kept publishing was the Imperial College, University of London, which was the doomsday data, which did not reflect reality, and it was very unpleasant to see that on the front page of the New York Times every day. And now we have data that's not only more accurate, it's interpreted every 3 days based on the reality of what's happening. And the reality of what's happening is we have containment strategies in place. Many states are locked down. We have therapeutics underway. We have increasing skill with treatment of this virus. And that's kind of what I want to get at. His latest data includes a recommendation for switching from essentially lockdown to containment, defined as social distancing, testing, contact tracing, isolation, limited gatherings, that sort of thing. So he has recommendations he's making recommendations that look very conservative on when to begin containment strategies of that type. And he's hooking it on the data coming in on deaths per day. And can you explain to me why he's hooking it to that data and not on something like numbers of hospitalized versus or numbers of positive tests coming in? Because it's my understanding that the death data is really a lagging indicator. I want to discuss that a little further, but first that question.
Well, I think that there are several reasons, but it's because the death data is important because we still don't have a denominator, right? We still do not know how many people are infected, and so with these kinds of limitations, we can only use hard numbers that are concrete, and death data is concrete.
What about?
I mean, that is an actual indicator.
Okay, so I want to make sure I'm hearing correctly. So to say admissions to a hospital is too loose because it doesn't include the rest of the denominator. Would that be about right way of saying it?
Yeah, exactly. And I think everything here needs to be in an epidemiology. Everything is related to denominator.
I get it. So the death per day is
without the denominator.
Yeah, and the death per day does not. I mean, if we're trying to create a fatality rate, obviously that's important. But if we're just looking at the outbreak, it doesn't need a denominator to be interpreted in day in day out basis. How much of a delay do you think? I mean, here's what I'm struggling, which is the next thing. I'm seeing a lot of really good outcomes in our hospitals, particularly here in Southern California. A lot of skill on the part of physicians, a lot of novel improvisations that are working, and they're just, it's way better than the beginning of the outbreak. When should that start to be reflected, do you think? Let's say we've been good for the last 10 days. When should that start to get reflected in the daily death rate?
Well, we have to We have to use science to be able to understand that and what we know of the clinical course of disease. And I'm not a clinician, but what I would say is that you have to look at the point at which people start to perish in this, through a clinical course, and then you can see how far of a lag it is. I think one of the things here is that people end up on ventilators and that they're sick for several weeks.
Right.
So what we're seeing in terms of a death toll today is really reflective of the number of people who came in a couple of weeks ago.
That's right. That's exactly right. And that was really just before the improvement started. Though I'm looking at Massachusetts just for argument, their daily death rate is really interesting because it goes from 0 this is on April 14th to 264 on April 15th to 0 again on the 17th. And it's so, I don't know, somewhere in there, it seems to me, is embedded the novelty of the therapeutics and the sort of what's going on in the hospitals in real time. I don't know. I just expect to see that daily death rate to be a source of information about how we're doing. How about that? Is that a reasonable way to say it?
Yeah, well, I think that over time, that's what we'll see, and I still think it's too early to see because, again, right? If people are in the hospital, and I'm, I would say within 2 weeks in the hospital, people might be you'll start to see people have very poor outcomes. But 2 weeks before that is when these mitigation strategies would have mattered, right? So you have a 2-week incubation period. You get somebody into the hospital who's having a poor outcome, and that might take another week or two, and so it's all lagged.
Yeah.
And it's certainly true. Everything that we are doing, all of the sacrifices that everybody has made here, that is making a difference in what we are seeing. And I think that how quickly California had very strong recommendations for keeping everybody safer at home, and really being right out the gate with all of this has made a very big difference.
Yeah, we're way beneath our.
And I do believe that we'll be seeing a difference.
Yeah, no, we are literally thousands of patients beneath what we were anticipating, tens of thousands, literally.
Exactly.
But the governor has put forth a plan that include preparedness for another spike, and so the beds remain available in the meantime, which is fine. I have no problem for him thinking worst case. That's his job. Now, the big question, of course.
Well, but we also have to remember. Oh, sorry. Go ahead.
No, you please finish. Remember.
Well, I was just going to say, but we also have to remember, it's not that the virus has disappeared. We're still seeing cases here, and so the minute that we start relaxing our restrictions, we're going to see more cases. So that's the problem. Without a vaccine, we're still at the mercy of this virus in so many ways. Right,
and so that's the next thing I want to talk about is and you use the word relaxing. Is there some number of, they seem, again, as we said, they're hooking it to the daily death rate. They want the death rate to be 0 before they lighten things. And that may come sooner than we think, but as it is now in California, it's due about the second week of May. They want it to be 0, and then we start doing things other than locking down. Is it possible? Well, of course it's possible. Do you think it's likely that we are going to be good enough at social distancing and wearing masks and isolating and and reporting and testing and all these things that even if there is a slight uptick, it will only be that. It won't break out again.
Well, we that's all dependent upon how well people are social distancing and how well people do their part, and it's really hard to do. I think that this is something that's why these kind of blunt instruments like social distancing and staying at home actually work, because there's not a lot of room for maneuver within those. And so I think that the problem is also going to be that we are, we're really at the mercy of how well everybody does in terms of social distancing and wearing masks and making sure that everybody does their part.
I don't know. I think people.
We don't have a therapeutic. We don't have a vaccine.
Well, but we might have some good therapeutics coming in, right? By the time we get to May, there might be some pretty good therapeutics that could change things. That's what happened with the AIDS epidemic, right? We started getting really solid therapeutics. And I'm hoping we have a similar, if history is any indicator, that we'll get somewhere quick with this one as well, but we'll see. But the other thing is, I think people are so freaked out that, when you go outside, I don't know about you, when I go outside, people recoil from one another and get angry if somebody's not wearing a mask. And I assume that's going to stay that way for a little while.
Well, I think it's important that it does. I think that what we know is that wearing a mask does reduce community spread. Wearing a cloth mask, you don't need an N95, you don't need a surgical mask. Wearing a cloth mask will stop speech droplets. And speech droplets are a very large part of transmission. And in fact, there have been several studies that have shown that that if every person wears a cloth mask, that we could even drop the transmission to the reproductive number that we always talk about to below zero, to below 1, excuse me. And I think that that's really, really important. And, so one thing I always like to say is everybody needs to keep their droplets to themselves. Yeah. And that's exactly what this idea of wearing a mask is, right? It's not about you being protected from me, but me protecting you from me. And so if everybody does that and does it well, we should see a very large drop in number of cases.
Is there a reason?
But also.
Go ahead. That's also
in addition to social distancing and hand washing and everything else.
Right,
It's not
what I'm hoping,
sorry,
again,
I want to make that clear.
I get you. And what I'm hoping is that because we are so flipped out and anxious about this, that we will practice extremely diligently, and maybe it won't be that different than the lockdown. Maybe we're not going to be going to restaurants, we're not going to bars, we're not congregating in large groups. We are afraid of each other. And I don't know. I think getting about may not make that big a difference. We'll see. I mean, we're going to find out one of these days, right?
Well, I mean that day will come, and I think that there needs to be better messaging about masks. I would love to see. What I've been waiting to see is where are all of the fashion designers and people handing masks out to people? I would love to see.
That too, yeah. Yeah, I thought about that.
And I'm not talking about selling it. What I would love to see is the real there needs to be more philanthropy in general for all of this. But I want to see people stepping up. I want to see all of these designers handing masks out to people, handing masks out at the food distribution lines and to people everywhere who need them, and not, there are a lot of people who can buy them or who can make them, but I just think that this has been a really big problem with the messaging. Sure, tell everybody to wear a mask. That's fine, but we're not a society that knows how to do that ourselves really all that well. We're not used to it. So I think that, I would really love to be seeing a lot more involvement like this. I have to say that's one thing I'm waiting for. I'm waiting for seeing all these big designers and people who have the opportunity to be handing out masks and doing their part in helping slow the spread.
I bought some last week, but they still haven't arrived from a company that I buy clothes from online, and they offered it, so I bought 6 of them, but I still haven't seen them. They may have run out already. So.
And hopefully they're launderable, that you can throw them in the washing machine.
Yeah, you can wash them.
Yeah. So I have a personal question. I can't help but ask you. So I'm a 61-year-old with hypertension and prostate cancer, and I have signed up for Governor Cuomo's frontline action in New York to go to run an ICU. I had lots of experience in intensive...
And dry eyes.
Yeah, and a dry eye syndrome. And I had lots of experience running ICUs, and I did an interview with them, and I have all the skill sets they need. So I'm going to go if they need me. How should I stay well?
Well, I first of all, I laud you for doing that. But it's a question that we all have for the people that we love. There's so many people with underlying conditions, and it's true that people with underlying conditions have a higher probability of poor outcomes. So the thing that if you're going to be putting yourself in the belly of the storm,
line of fire.
you need to be doing everything you can.
Well, so,
in the line of fire.
Yeah, so
and you don't want to be. This is what I've said before. The problem without PPE, the fact that we have not had enough PPE, which is just outrageous and unimaginable that this has not been solved.
I get that. I think that has, at least in the front lines in the ICUs, I question them about that, and they're like, we got gear for you. They don't worry about that. My question is, are there anything from a technique or anything we've learned about the transmission? I mean, I keep hearing that hands are the main unit, and then splash is the other, and aerosol's the other. And if you can sort of protect yourself against all that, you're usually pretty good. It's not like the ICU docs are dropping; they're just burning out.
Right. Well, we've seen this in all the I've been working in Ebola for a very long time, and this is where we see problems is that there's fatigue. There are only so many healthcare workers out there, and people are getting tired. They're working long shifts, they're working long hours, and it is exhausting work, and people start to make mistakes because it's so tiring, it's so stressful. And it means that healthcare workers are superhuman in so many ways, but they are still human, and it is very, very difficult to be able to be doing what we call the donning and the doffing of the PPE, and that is often where we see the issues is people get tired and then they infect themselves.
So it's just
by no fault of
a lapse in technique. That's the primary means. Would that be right?
That's yes, yeah, and we see that with so many diseases, so many epidemics.
Yeah.
Ebola, we saw that too.
Yeah, great. I'm generally a little.
Although this is much more complicated because it's respiratory.
Yeah. All right. Well, it's going to be what it's going to be. So let's go back to epidemiology again. Let me look at some of the data over at Health Data. Is there a reason why they want to go to 0 deaths per day before they lessen containment strategy? I mean, is that just an obvious and convenient line in the sand after which to begin, or is there some science there?
Well, the reason that you want to go to 0 deaths a day is that you want to make sure that you are not that you're beyond that your health system is able to cope with the number of cases that are coming in, and that you also have that the community transmission is at the lowest that it can possibly be. So that's really the proxy for it. There's and with all of these things, there's never just a line in the sand that this is exactly the moment that you stop.
Right.
We use markers because we think that these markers are helpful. But just like when we talk about things like how far is this virus spread from person to person, we say stay 6 feet apart, but we know that droplets can go further. And as we learn more about this disease, we say, okay, well, we know it maybe have some capacity for being aerosolized, and so people need to stay further apart if they can, and they need to be doing more things. So, there's no exact number here.
Got it. And then I'm just looking at the Dr. Maurice Tov. It's uncanny to me how accurate he's been on the daily total death predictions for the United States of America. That's been sort of remarkable to me. He's been spot on for about a week, which is I can't imagine the data that he has to cull through to get this data. I think those are most of my questions. I mean, I could ask you about the epidemiology, I think, all day, because it's not a field I'm super familiar with, and I'm trying to understand what the models actually tell us, as opposed to just sort of, the models don't really predict the future. At best, they kind of tell us where we are and kind of where we're going. Would that be about an accurate way to say it?
Well, I always like to say, so what you hear people say all the time is all models are wrong, but they're still useful. But in addition to, models are just that. They're just as good as the data that we're feeding into them, and we're learning about this virus. It's totally new. But the other thing I would say about models is that they are not our destiny. They are one vision of our future.
Right.
And so as we do more and more to mitigate the spread of disease, as we, as people become better we as we understand more about what therapeutics are going to be available, as we get closer to vaccines, all of this will change over time.
Yeah.
And as we learn more about how contagious it is, how many people, this brings us back to where we started at the beginning. How many people have actually been infected?
Right.
Who's immune? Who isn't? Can people get reinfected? How long does immunity last? I mean, those are really the key questions that will really inform a model and give us data that we can really know to be true. Right now, these are all predictions.
And let me finally put you on the spot, and you cannot answer, but do you hear anything, rumblings about therapeutics or prophylactic agents that sound encouraging to you?
Well, I think that there have been some good, and encouraging data about remdesivir and other things. But for example, again, these are preprints. There is no control group.
Right, no
this
blind.
is all just encouraging. I will say, just as a layperson who is not a clinician, I'm an epidemiologist. I'm a clinician. Of course, this is all encouraging. And isn't this really terrific? How quickly these clinical trials these studies have come up and have been moving forward. So I, just like you, am looking with great interest to see what these studies show us.
Right.
And I'm very encouraged.
The other thing, from the standpoint of epidemiology, might be interesting to get your comments on, is the health inequities. I know that's not really your specific area of research, so you are looking at immigrants. Any sense of what we're going to learn about that? I mean, so far to me, it's hard for me to frame this in an accurate way. We know there are health disparities. Anyone that works in medicine knows this. It's something that our profession has been looking at and struggling with for a long time. It's not for lack of intent. It just has not been very effective in terms of what we've done. I was delighted to see the state Surgeon General just before this outbreak attempting to bring in a campaign about adverse childhood experiences. I'm of the opinion that childhood trauma is the primary source of so many adverse health outcomes later in adulthood. Do you have any opinion about that?
Well, I mean, we know that this COVID-19 is a reminder of why inequities harm us all. I mean, this is another situation here where we have such inequity and access to care, comorbidity, socioeconomic status. All of these things make people more susceptible. That is not only true here, but that is true everywhere in the world. And we see that people who are have lower socioeconomic status have poor disease outcomes, and for so many reasons. And we're seeing this here play out just as anybody would predict right here. And it's really unfortunate. It just shows that it is critical to be fixing all of these things before you have a pandemic, because when you have a pandemic, all of this is exaggerated. The outcomes are exaggerated, and I don't mean being exaggerated like somebody's exaggerating them, but I mean aggravated, much worse.
So wait, I think that this should be a very... Yeah, I want to drill into what you're telling us. So from my stateside point of view, I look at adverse childhood experiences, childhood trauma, and trauma-informed care as one way to potentially change health outcomes in adulthood. With your global perspective, do you have anything you see that, because there's an awful lot of hand-wringing and gnashing of teeth and woefully little solution. And to me, trauma-informed care is one solution. Do you see other solution based on your global perspective?
Well, I mean, I think that this just shows how the consequences of healthcare disparities, and this is something that needs to be fixed in our society.
But hold on, but it's worldwide. It's worldwide. And so do you see anything that we maybe can't see stateside that you bring from that global perspective? I'm wondering if, yes, it exists. Yes, it's everywhere. But in terms of solution, anything that you can, any novel insights that you have from, I don't get the global perspective, right? I was surprised to hear you say that it's truly a global phenomenon. It makes sense that it is, but does that give you any notions of solution?
Well, I'm just going to, unfortunately, the solution that I'm going to give you is a canned solution, because I don't have a solution to this is not just a public health solution. This is an economic solution. This is a big issue in general.
Okay.
I'm going to say it again. We know that health, inequities contribute to poor and adverse health outcomes.
Right.
And we have not done enough, whether it's policy, legislation, whatever it is, to do it. And we actually need to put our money where our mouth is. And we see this in pandemics. We know that crowding is a problem with disease prevention and control. We know that hygiene is a problem with disease prevention and control. We know that all of these things, all of these health disparities play right into when we have a disaster of any kind, that the people who are already struggle more.
I completely
and that's
agree
what we
with you.
see all globally.
The crowding, I don't think enough is made of. I think not only does crowding need to be addressed, we should have anticipated based on crowding. That's where we missed our opportunity in New York City, I think, right?
Yeah, I also agree with you. I mean, listen, we could spend a lot of time saying coulda, shoulda, woulda.
No, of course.
But yes, I do agree with you that that's true. But I think that what we're seeing, right now is this lack of investment across the board. You pay now or you pay later, and boy, are we paying right now.
Right. That's right. And here we are. But I appreciate your work. I appreciate you sharing with us. And again, I was going to give you that website. I guess it's susandrdrew.com. Whoop, we're not hearing you.
Oh, hello. drdrew.com/UCLA fund. Go Bruins.
Go Bruins. And were you on Bill Maher? Were you on Bill Maher recently? Is that what these images are from, or was that an older, prior to the current epidemic?
Which I don't know which image you're
looking at.
You're looking at.
You
but,
talking to Bill Maher, and I'm wondering if you got into his head at all about all this.
Well, I mean, I had a nice conversation with Bill Maher at the very beginning of this whole. It was actually at the very beginning of this, and the reason that he invited me on is because I've been working on pandemics in other places. We certainly had a good discussion about it, but I think I said the same thing. I said we haven't invested in pandemics, and so that's going to be a problem. And what we're seeing is that we didn't invest in pandemics, and now we have a problem.
Yeah, he needs to bring you back. So
that's true.
Do a post or intramortem. So okay, well listen, I really appreciate you spending us and sharing your knowledge with us. It's people are scared, people are confused, and
for taking time out of your
and I know
schedule.
this is literally the middle of a war for you, and you're in the midst of it. I'm happy to help. I'm happy to do this, and I'm glad that people like you who have a platform,
have a wide audience are talking about it and bringing good information to people.
Yeah, it helps people. We try to get in here every day and just sort of gather people together and give them information, because otherwise,
don't say every day.
Well, most days, it's a nice It's not nice. It's an important alternative to what's going on in the press, which is a lot of fighting and politicizing. It's just hard to know what's what and what's important and what isn't.
It's nice to hear the experts.
Yeah, and just the experts.
Not in a soundbite either. Like getting to hear the whole story.
And I'm not in any way diminishing Dr. Birch and Dr. Fauci. Keep listening to them. I've certainly listened to Dr. Fauci my entire career, and like I said to Dr. Rimoin before we got going, that I got on radio because Anthony Fauci was there saying we've got to educate about AIDS, we got to get people to change their behavior, and we did. But more importantly, we came up with some really cool therapeutics that changed the whole shape of things. And I'm really hoping and praying that's where this one goes too. So we'll see. Anything you'd like to refer people to or remind people of before we wrap it up?
Wash your hands.
Oh yeah, well,
Well, I just, I just like to. I just think that this has been it's been a really great discussion, and I think that people are interested in learning more about our study. I think you put a website up. I think it's giving.ucla.edu/Rimoin, RIMOIN. That's how they can support this study. The more that we're able to screen healthcare workers and give them this information regularly, the better it is. It's really important that healthcare workers are able to protect themselves, and we're trying to do that here. In our own community.
Is the dashboard going to be there? I want to start incorporating, monitoring that dashboard into what I look at. Is that at that website or somewhere else?
Yep, the dashboard will be this is the Giving website, again? And we're working on a website that will be available to everybody. That should be up in the next week or so. Everybody will be able to track it, and I'll be able to give it to you.
Okay, great.
It's giving.ucla.Rimoin. / Rimoin. It's giving.ucla. Let's see. I'll tell you exactly what it is. I'm not.
We put it.
I know, right? This is like one of the. It's giving. It's giving.ucla.edu/Rimoin. RIMOIN.
Okay, I can do that. All right.
Excellent. Well,
I'll put that up here.
Thank you so much, and we will await your your contact with us in terms of giving us how to get to that dashboard and when the website's ready. Okay.
Yeah, absolutely. No, I'm always happy to help. As we discussed before I came on, I've been listening to you since the beginning of Loveline. I grew up here in Los Angeles. I think it's really great what you've been. I'm happy to finally be on the air with you, and thanks for really bringing this information out for everybody. I think that it's really, really important.
Don't be surprised if you get another call.
Right, we might need you back as the data plays out, and especially if you find anything
maybe for Fox
of a genetic or prophylactic nature or anything like that. I want to hear that immediately.
I know.
All right, Anne, thanks so much.
Well, I'm happy to share. Thank you so much.
Take care.
Have a good weekend.
Yep.
All right.
And
bye-bye.
Susan, I'm going to wrap.
You too. Have a good weekend, everybody.
All right. And I'm going to wrap up the restream. People have been listening diligently.
I know. They've been very patient and nice.
Yeah. And nobody had any real questions because they got them all out this morning. Somebody wanted me to cover Illinois, which I'll be happy to do real quick. One day until the peak, and the peak is at roughly 100 deaths, and then you're out of it May 1st. The peak in resource utilization was yesterday, and you easily met your resource needs. 2,200 deaths are predicted in the great state of Illinois. That's a lot. So hang in there. Keep your social distancing. Keep doing all your diligent work. All right. So with that. Great job, Dr. Rimoin. I agree with that. And zinc
feathering it, true.
Yeah, they're just feathering it.
Yeah, they said, should I cut my hair or just feather it?
That's really funny. Zinc is looking good. I take zinc. People are interested in that. Connecticut, they've been asking about Connecticut since this morning, so let me do that. Connecticut is expecting containment strategies in June. There are 3 days until their peak death rate, which is going to be around 100 again. 2 days since the peak resource utilization, and you're easily meeting those demands, it looks like, from what I'm seeing here. And again, another total death toll around 2,700 in the state of Connecticut. And that's a lot. A lot. Again, remembering that 2,700 in California, which I'm sure we are 3 or 4 times the size of your state, we are anticipating only 1,600.
So if you get sicker as you go, these people are probably in the hospital for a couple of weeks before they...
Yeah, and so the daily death rate is reflective of people that have been in the ICU for a while.
So hopefully, we won't have new cases of people going in because we've stayed away from one another.
And we won't have new cases going in because of our containment, and we also have gotten better at keeping people out of the ICU. So there you go. And Dustin, I'm in remission. There's no such thing as really cured from cancer, but I'm in remission. Had a prostatectomy 11 years ago. Best form of zinc, I don't have an opinion on that. No, there are good zinc supplements out there, and I'm hearing different dosing, so I'm not quite sure how to recommend that to people yet. Epilepsy and COVID-19, I don't know that that's a specific risk factor, the way, say, hypertension is. I just read an article that was listing all the different risk factors for people who required hospitalization. I did not see seizure disorder on that list. Yep, D3 is a good supplement as well as some people are saying B and B12. I'm not so sure about that, but vitamin D, vitamin C, zinc, all look, magnesium perhaps, also look like useful adjuncts. Okay.
I'm doing all those ads for South Carolina. Magnesium. So, yeah.
South Carolina. Somebody is a respiratory therapist in South Carolina, so I want to help him. So let me do that.
CBD oil.
South Carolina. CBD oil may help with sleep and things like that.
Anxiety.
South Carolina, really very limited deaths. 3 days since peak resource utilization, very low levels of hospitalization. 217 total deaths in the great state of South Carolina. That was the last place I set foot out of California before I came back and quarantine. But South Carolina looks pretty good.
Somebody said, what does your crystal ball say about how the unskilled homeschool will affect the kids?
It's
a great question.
How the homeschooling.
My kids are so lucky I didn't have to homeschool them.
I'm predicting that it may have a net positive. I don't see it it's going to be neutral to net positive is my expectation. It's helping people structure their day. It's giving teacher novel techniques to educate. Kids are very accustomed to screens. I was listening in, my kids are in graduate school. I've been listening to some of their lectures. I would rather myself be sitting there listening in this environment.
That's true.
And be able to stop and start and focus and take notes as I wish and not be distracted by any social engagement. I mean, this may end up in net positive. I think where we're going to have to worry about it is the new kind of learning.
Is the moms drinking too much wine?
There's that. But the new learning that we have to get focused on in this country is problem solving. And problem solving needs a little bit of kind of one-on-one kind of attention from teachers and trainers. And I'm not sure if this is an environment where that can happen. So in terms of real, coding problem solving, math problem solving, science problems, STEM problem solving, that may not be as well enhanced by this kind of training. I don't know. Or maybe we'll find out novel ways to kind of coach it up or tutor it or something. All right. So
free iPads. So do you want to mention the show tomorrow?
We have a dentist who repaired someone's teeth and a woman who got.
No, he's going to give her free teeth.
Going
Dr.
to give
Brady
her,
Smith.
He's going to give free teeth, and she now has COVID. Is that right?
She was on our show before, yes.
So she will get a report from him and her?
She emailed us, and you called Dr. Brady Smith, and he's giving her a new set of teeth, which sort of was held off because of this. But she thinks she got COVID. She's going to get tested.
She thinks she got, okay.
Yeah, I know. Tested. She didn't get tested she didn't qualify for the test because they didn't want her to get in an Uber and come to the hospital.
Okay, fair enough.
And then Dr. Randy Hauska also.
So Chelsea Hauska's dad from...
we think teeth are important.
Yes, I just got an emergency I've got to deal with right now.
Okay, and then also the ever so famous Mike Catherwood will be co-hosting and taking your questions. So you can call in to 984 Ask Dr. Drew or 9842 Dr. Drew, and tomorrow 2:30 p.m. Sunday, April 19th.
All right, so we will see you then. I've got to handle some issues, and thank you all for joining us. Thank you to Dr. Rimoin, and we'll see you tomorrow.